you. My name is Dr. Emmanuel Soma. I'm going to make a presentation with Dr. Charles, Eric Halder, and Dr. Abid Hassan. We work with IOM based in Cox's Bazar. We're going to give some practical insights into how we respond to the hepatitis C epidemic among the Rohingya refugees in Cox's Bazar. You can go to the next slide. Thank you. So we will structure this presentation in a way where we'll give a short introduction about the IOM's response in Cox's Bazar. Then we'll look at the IOM's operational role in Hep C. Then we'll consider the operational challenges, the clinical challenges, and then we'll go into detail about the study that we are currently doing about the causes of the high prevalence, and then look at the coordination mechanism and priority actions. Next slide. So just a background about IOM in Cox's Bazar, and maybe just to start with the Rohingya population, just to add to our voice. This is a population that has faced repeated displacement from Myanmar due to conflict. And we know that the largest influx happened as of 2017. About 700,000 came into the country. And as of now, as of December 2025, it's at least 1.15 million refugees who reside in 33 overcrowded camps, and also that's in Cox's Bazar district, as well also in on Basancha Island, and they face poor living conditions, and this predisposes them to the recurrent disease outbreaks. We've had different outbreaks of diphtheria, measles, COVID, even COVID-19. Acute watery diarrhea or cholera, and even dengue. And IOM as a partner ensures that we deliver multi-sectoral humanitarian support, and this covers health, mental health, and psychosocial support, WASH, shelter, site management, protection, disaster preparedness, and also livelihood for the Rohingya refugees and also the affected host community. Currently, IOM supports and also operates in 32 health facilities across Cox's Bazar, Basancha, and Noakhali, and we average around 1.2 million clinical consultations a year, and this covers primary healthcare, secondary healthcare, referrals, sexual and reproductive health, and MHPSS. And as has been highlighted by the other colleagues, the Rohingya have been noted to have a high endemicity of hepatitis C, and unfortunately we see the pregnant and also the young women are at high risk, yet we are not able to provide treatment for them. And we closely coordinate with the government of Bangladesh, WHO, MSF, and other UN agencies, plus also other health actors that were quite clearly shown by my previous colleague. Thank you. Next slide.
Thank you, sir. So from here, I'll be sharing the IOM's frontline experience responding to the hepatitis C epidemic among the Rohingya refugee population. So let me begin with how IOM has structured its operational response. Our approach is fully integrated within routine healthcare delivery, meaning hepatitis C screening, diagnosis, and treatment. They are not standalone program. They are embedded into the primary healthcare system, serving this community. At the community level, our community health workers conducted active case searches, going door to door to identify individuals who may not otherwise seek care for it. And for screening, we use rapid diagnostic test for all individuals over the age of 11, which enabling mass screening at scale. Currently, we operate across IOM 11 direct health facilities, one Government of Bangladesh health facility, and 5 primary healthcare centers that is run by IOM's implementing partners. We have also planned to expansion of 11 additional facilities spanning IOM and Government of Bangladesh site in both Cox's Bazar and Bhasanchar. For confirmatory diagnosis, we have established sentinel surveillance at 6 of our primary healthcare center, where samples are collected and transferred for RT-PCR testing at the WHO IDCL lab. Treatment is then provided at 3 primary healthcare centers with a 3 months regimen for non-cirrhotic cases and 6 months for those with cirrhosis. And critically, we have structured a referral pathway from screening to sentinel sites to treatment center. And for the most critical cases, IOM's dispatch and referral unit, which provides 24/7 support across all camps, and it provides direct transport from the camp to the district shoulder hospital and even the divisional hospitals. Next slide, please. Now, while the operational framework is in place, implementing it in the field is far from straightforward. So I want to be candid about the challenges we face because they are significant. The first and most pressing challenge is the sheer burden on our health facilities. The prevalence of hepatitis C in this population is extremely high, which means mass surveillance becomes a necessity, not a choice. So this had required extensive involvement from our healthcare workers who are stretching an already overburdened systems and leading to an excess delays and long wait time for the patients. So compounding this is a serious shortages. Sometimes there is serious shortages of diagnostic kits and medicines. The treatment medication must be imported, and because primarily it was from India at a cost of approximately 100 USD per patient. While this is significantly lower than the 820 USD price in Bangladesh, so meaning it remains a heavy financial burden given the scale of need. To date, IOM has been able to support treatment for approximately 1,000 patients, and WHO has supported over 2,000 patients through IOM. But the demand continues to far outpace available resources, so we urgently require further support. Next slide, please. So beyond supply, we face two additional operational challenges that affect our ability to ensure treatment completion. The first is patient loss to follow-up. Hepatitis C treatment requires months of adherence, but the Rohingya population is highly mobile. Movement between the camps especially and the outside of the camps for the economic activity, meaning patients frequently miss their appointment or discontinue treatment before completing the full course. This is not a simply logistical problem. Incomplete treatment can contribute to resistance and reinfection. The second challenge is related to documentation. Many newly arrived refugees lack proper identifying documents. This creates delay in verifying their identity, enrolling them into the care, and results in missed opportunity for early intervention, particularly among the most vulnerable who may arrive in poor health. Next slide, please. Okay, so along these operational realities, we face important clinical challenges that we want to highlight for medical community joining us today. The first is treatment limitation for a specific population. Current treatment protocols have limited, or in some cases, no options for children under the age of 11 and for pregnant women. These are two highly vulnerable groups, and the gap in available treatment option for them is a significant clinical and ethical concern that the global health community must address. And the second clinical challenge is the absence of clear guideline for managing reinfection and complex clinical cases. In a setting where transmission risk remains high due to living condition, reinfection is a real and recurring phenomenon. So without standardized guidance for the clinicians, including our own terms, like we may face significant uncertainty in how best to manage these cases. Next slide, please. So here I want to draw attention to a challenge that is both an operational and clinical concern: the co-infection of hepatitis C with TB and HIV. So co-infection with these diseases significantly worsen disease severity and dramatically complicates treatment, as patient must manage multiple drug regimens simultaneously. And even for this particular co-infection, we cannot immediately start the treatment because of the co-infection. So we have the data from our own assessments through March 2026, which actually tell a sobering story. Among 714 people living with HIV assessed by our teams, and from that 714 people, 61.14 were found to be co-infected with hepatitis C. And among 75 TB patients, 16 had a hepatitis C co-infection. So these are not the marginal figure. They represent a substantial proportion of the most medically complex patient in our care, require, who require actually highly coordinated and multi-disease treatment. So in closing, for the operational challenge, IOM team in Cox's Bazar actually is committed to continuing and strengthening the response. Next slide, please. I would like to request my colleague, Dr. Charles, to carry forward from this slide. Over to you, Dr. Charles.
Thank you, Dr. Emmanuel and Dr. Rabid. This is Dr. Charles Erikalder. So the earlier speakers mentioned about the uh, high prevalence of hepatitis C in the Rohingya refugee population, but there are some questions remain. What are the factors that are causing high prevalence? So the high prevalence, the cause of the factors, it is still unknown. So that's why we are investigating the socio-demographic factors or the medical factors, traditional or behavioral factors that are contributing to the hepatitis C virus among the Rohingya refugee population. So we have started this study last year. We are almost at the end of the study. The analysis is also completed and we'll publish the results soon. Next slide, please. So what we are investigating here and what the results will publish, it's about the socio-demographic characteristics, the relationship with the high prevalence of the hepatitis C. We are exploring whether there are relationship between the occupation, their past occupation in the Myanmar, or is it related with the arrival in Bangladesh in terms of the years, or is there any relationship with the family status of the family members and other demographic factors. We are also investigating about the medical history, for example, the blood transfusion, the history, place, and time, and also the other medical histories like medical injections, needle prick injuries, surgeries, hospitalization, or the procedures, also co-infections and comorbidities. We are also saying about the home delivery, whether it is related with the high prevalence, and some procedures like the evacuation of the consumption products. So these things we are exploring from the quantitative perspective. We're also exploring about the traditional practices, for example, the circumcision, tattoo history, or piercing histories, or shaving, whether these are related with the high prevalence. And we are also exploring about the other risk factors like recreational injection drugs, or the history of incarceration, or the spousal history or the family history of hepatitis C virus. We are also exploring about the sexual activities, whether it is related in this area, and mental health impact we are also exploring, and the knowledge, attitude, and practice we are also exploring in relation to the high prevalence of the hepatitis C virus. So in this study, we are doing a biphasic approach where we have the both qualitative and quantitative part. We are in phase 1, we completed with the quantitative part where we had a case control study engaging 900 cases and 900 control. And following that, we had a qualitative study composing of the focus group discussions and key informant interviews with the caregivers, healthcare providers, and the community members. So with this study, we hope we can find out the risk factors for the high prevalence of this disease here, and that will help us in addition to the case management, in addition to the all other measures. It will help us for the prevention to develop a proper risk communication and community engagement strategy so that we can reduce the transmission in this area. Thank you very much.
Yeah, thank you. Next slide. So I'd like to highlight some of the strong coordination mechanisms that is helping the response and also still presenting a challenge. We continue to implement under the overall policy support of the government of Bangladesh through the RRC office and as well the civil surgeon office. And our main primary stakeholders still remain to be the Rohingya refugees, and we are actively engaging them through the community health workers and community-based activities. There's the coordination at the screening sites of the local community health workers who they refer to the screening sites from the local catchment. There's also the sentinel sites for the confirmatory diagnosis, and this also coordinate directly with the camp-based health facilities where the referred RDT positive cases are sent to the sentinel sites. And in the treatment center, there's close collaboration within IOM and also non-IOM sentinel sites. We work closely with WHO, the Hepatitis C task force that's in Cox's Bazar to ensure for the response, and this through the technical guidance and for supplies, and also work closely with other actors like BRAC, who are mostly for HIV, TB, IRC, MSF, UNICEF, UNHCR, and also for resource sharing. And there have been quite great efforts in which partners have been contributing, whether it's diagnostic kits or whether it's treatment to the entire response. And with these dedicated sites, we ensure there's sentinel surveillance and there's treatment support for efficient use of resources and avoiding duplication. Thank you. Next slide. Finally, I want to speak about the priority actions and where we feel that support and collaboration are needed. And this is just to add to our voice to the discussion. As IOM, we will carry on with concluding the research on identifying the risk factors. So we will not share much. We would want you to read the study once it's out. It will be quite interesting, but also we would encourage all actors to undertake extensive risk communication and community engagement to halt transmission. We know there are various perceptions of the disease among the population. We also need extensive additional human resource. At the camp, there is quite a high turnover, and we also need the supplies. We've highlighted the significant cost to treat the actual or estimated cohort based on the prevalence, and also to support the mass screening, diagnosis, and treatment of all patients, and also, if it's possible, through the government for the advocacy of the production of Hep C medicines in Bangladesh at a much lower cost as it is for other medications, and as well, how can we ensure the availability for all treatment of all age groups, especially the under 11s that are not currently considered, and also how we can factor in those that are pregnant. At this moment, I would say thank you to the presenters and also to you for listening in, and would welcome the questions in the chat box and also at the end of the meeting. Thank you.
Thank you, Dr. Soma. Thank you all to your other IOM colleagues for sharing their knowledge of the response and what's are critical next steps